Mark. Oh, sorry, I was going to say that. We're recording the webinar. Our speaker today is Mark Bronstein. He is the Honorary Professor at the University of Queensland, a visiting scientist at the CSIRO's eHealth Research Centre, the Professor of the Practice Emeritus at the School of Interactive Computing at the Georgia Institute of Technology. And Mark's going to be talking to us today about the University of Queensland's undergraduate FHIR project-based training for Australia's digital health workforce. Mark, I'm going to hand it straight over to you.
Okay, let me see if I can get sharing working. Are you seeing my screen?
Yes.
Sorry about the time confusing. Well, I'll just dive right in, I suppose, but thank you for having me. I like to talk about this course. I think it's something that's important, and I hope the model will get adopted beyond just the University of Queensland. The model actually goes back. I started it at Georgia Tech before FHIR came along, and changed it to FHIR when it did come along, and we've run literally thousands of students through the course, most of them online, ever since. And some of them even start companies. It's really amazing the impact it can have. Let me begin with the Topol report. Eric Topol is a noted academic researcher from Stanford, actually the Stanford Research Institute. And in 2019, he chaired an independent report for the National Health Service in the UK on preparing the healthcare workforce to deliver the digital future. And I just quote one sentence from the opening introduction. There is little point in investing in the latest technology if there is not a workforce with the right roles and skills to make use of its full potential to benefit patients. I think that's true, and it's been the motivation for creating this model from the beginning. So beginning in 2018, actually the first year I was here, we created the Digital Health Software Project course at the University of Queensland. The rubric is Comp 3820, and I use that a bit, so I'll make sure you know about it. And the whole rationale for the course, as it's explained to students, is summarized in this sentence. The course will help you, oops, I've got stuff in the way here. Help you learn the basic fundamentals of digital health technology through hands-on experience and through exposure to the real-world use of data and informatics in the health industry. I learned the hard way that didactic courses just don't really stick. I mean, you can stand up in front of students and you can lecture as much as you want, but in my belief is that until you give them hands-on exposure to whatever it is you're teaching, it's unlikely to stick, and it's unlikely to get the students truly interested in the subject matter. So we started in 2018, as I said, over on the left there with 6 students. And the numbers bounced around right through the COVID years. I obviously wasn't here in 20 and 21, but I was back in 22. Now, I can't claim that Sparked, which began in July of 2023, to coin a bad pun, sparked the growth in enrollment. But starting that year, we all of a sudden had over 60 students And that number has grown to 80 and nearly 100 this year. And the last 2 years, we actually artificially capped the enrollment. The numbers would have been greater. But it is a project-based course. And when I explain how we do that, we're limited by the number of project mentors that we can recruit, although we've got an apparent solution to that beginning this year. Now, the course consists of 3 components. An online course based on the edX platform, which UQ uses. And this means that precious classroom hours aren't devoted to providing much in the way of didactic material. There is a bit of that, mostly introductory in nature. But the students really learn the information they need about healthcare data standards and interoperability standards, and the applications of digital tools in healthcare through an online course. That's supplemented by lectures from domain experts, both from Australia and from the US, and I'll show you that in a moment. And then finally, the real heart of the course are these mentored Smart on FHIR app development projects. Now, up until this year, the mentors were generally people from industry, people from healthcare itself, and some of the researchers here at CSIRO. But this year, we adopted a new approach, which seems to be working very well. I'll explain that in due course. The edX course is updated every year because things are just changing at such a rapid rate that it would be obsolete if we didn't do that. So I'm just going to show you a bit about the 2025 version of the course. I've already started thinking about the 2026 version. The course consists of videos that are posted on the edX platform. This is a screenshot from the first video, the module 1 video. And you'll see in the lower left there that the videos consist of sections, components, and we turn the videos into an H5P object so that the students can click on these tabs and skip around in the course as they wish to. The course consists of 3 sections, if you will. The first is the background material about healthcare systems, key informatics tools that are used in healthcare, from the hospital to the physician's office to health information exchange to, importantly, patients getting involved in their own care. The next part consists of all the major data standards, including the NDC drug standard, which is only used in the United States. But we include that because at some point I'm hoping this course might even get used back in the US. And that followed by interoperability standards, the historic HL7 interoperability standards, their evolution right through the clinical document architecture. Oops, I'm sorry. And finally, the pre-FHIR clinical decision support standards with examples, including Dr. Homer Warner's HELP system, the MICE and Internist, and the Arden standard for sharing clinical logic. The second section is the modern standards. It's only in 2 parts, but they have a lot of subparts. First, of course, is FHIR, and the second is SMART. And the third are the various applications of digital health, from mHealth, mobile health, public health, population health, some examples of advanced FHIR applications such as the DICOM and M code, the cancer terminology that's been done in FHIR, the Health Evidence Knowledge Accelerator, which is an effort to literally bring medical knowledge and medical research into the FHIR standard, and an example of population level FHIR-based applications. And finally, a new section, new this year, on healthcare AI that gives examples, but also explains a bit about AI for students who don't know that. In total, it's about 4.5 hours of online course material. And as you can see, there are on the order of 100 videos. And in blue, there are 13 activities, hands-on activities, where students typically go off to some public facility and do prescribed activities and answer questions based on those. Here are just a couple of quick samples. This activity from the FHIR module asks the students to go to FHIR, David Hayes' wonderful site, look up a particular patient connected to the smart sandbox, which David was kind enough to add as one of the options on FHIR just for this course. And then explore that patient's resources. Patient has a lot of resources. Answer questions. These questions are really about the use of data standards within FHIR resources. Another example is going to the smart launch platform and investigating its many options and features, because we want the students to use the launch platform later on to launch their FHIR app projects. As I said, there are in-class lectures, but they're really not, for the most part, presenting didactic material, except for the 3 lectures given by CSIRO people. And you can see here that we have Benson Kurse from Chamonix, who talks about My Health Record in detail. We have Tim Blake from Semantic Consulting, who talks about computable clinical guidelines, and Robbie Carr from Fluffy Spider, who talks about interoperability in the real world. From the US, we have Doug Horner, a fascinating guy who has a company called Medical Informatics Engineering, which is not terribly well known. It's in Indiana, but it's a notable company. They were the first web-based electronic medical record system, and he created one of the first successful health information exchanges. Lucy Ide from Remedy is an example of a pure, smart, FHIR-based US startup, in this case, focused on chronic disease management. And we have Graham Grieve, which of course is a big high point in the course. Jim Steele, Matt Cordell, and Jim Steele again, you may know these names, provide even more detail about FHIR and SMART and terminologies than are covered in the MOOC. We attract students, a broad-ranging group of students with, as you can see, an extensive list of majors, both graduate and undergraduate students, but more graduate than undergraduate. Students in things like software interaction design. It's wonderful to have those people in the course because interaction design is so important to healthcare applications. Various aspects of computer science and engineering. And as I said, a total this year of 97 students. I mentioned that the projects are from a novel source this year. Sebastiano Barberi teaches a course called Digital Health in Action, which is it's a completely online course. It's aimed at healthcare professionals out in the workforce who are interested in learning about the applications of digital health. And this year, he agreed to have his students mentor a project. The great thing about that, there are a couple of great things about that. Students learning from each other. So his students learn about digital technology from our students. Our students learn about the real world of healthcare from Stefano's students. And as you can see here, his students are cut across the spectrum from midwives to clinical nurses to physicians, pharmacists, radiologies, just a broad range of backgrounds and roles. And here are some examples of the projects they've proposed. Now, what I find interesting here, can you see my pointer? Can you see my mouse pointer?
Yep, I can see it.
So these first 5 projects are all about workflow and process, improving various processes from creating or obtaining preoperative consent to ambulance deployment to enhancing ICU step-down efficiency through digital discharge coordination and so on and so forth. And the pharmacist has proposed an interesting project about bridging the language barrier within public health and hospital services. And then these are not all the projects. These are just some of the projects. And here's one on AI enhanced clinical decision support, and another one on persistent pain management. I mean, this is 3, 4, 5, 6, 7, 8, 9, 10 projects. There are 27. Now, to give you a sense of what these students do, I'm going to show you, these are the 2025 projects. And I've highlighted the 3 that got the highest evaluation from the faculty and people from the industry who watched the end of the semester project presentations. The first is an app for managing chronic obstructive pulmonary disease. It brings in data about the patient's heart rate, about their blood oxygen level. These are, of course, from devices in the patient's home, and monitoring of physical activity through things like a smartwatch. Does an assessment, asks the patient questions, a few of which are shown here, makes recommendations, which can be summarized and emailed to the patient by the physician. So this is a very interesting example of patients directly having input into their care and receiving feedback about what they might want to do to improve their care. The FHIR visualization tool project is a bit unusual because it's quite technical, but they did a really good job. Certainly not something that a healthcare provider is likely to want to use, but you upload a FHIR bundle. Here are the resources in the bundle here, and you can explore the bundle in various ways. Here I've just shown that you can search for conditions that have been confirmed, and there are lots of other interesting ways of exploring the data. This may have been the most ambitious project clinically and technically. So if you go to the MTP Connect, the Australian Life Sciences Innovation Accelerator, one of the things they talk about is clinical trials and the things that might be done to improve the management and the participation in clinical trials. And this is the one they focused on. Adopting artificial intelligence to promote access and participation in clinical trials. If you're not familiar with it, the U.S. National Library of Medicine operates a site called clinicaltrials.gov, upon which, as of yesterday, when I made this screenshot, there were over 550,000 trials posted. These are just the first 3 that came up. Of those, 66,624 are actively recruiting patients. Now, the research shows that a bit over half of the clinical trials will fail because they never recruit the number of patients they need. By the way, of those 66,000, 1,733 are here in Australia. So why do trials fail to recruit successfully? Well, you've already seen one reason. There are just so many trials. No doctor or patient has time to sort through them. Secondly, when you focus on a trial, they have complex and typically highly technical inclusion on the left and exclusion on the right criteria. And these aren't even all of the inclusion and exclusion criteria for the trial I selected. I just didn't have room on the screen to show them all, but I think I can make the point with just this much. I mentioned the Healthcare Evidence Accelerator earlier, and it develops tooling to try to bring FHIR into clinical research and medical evidence. And one of its tools, and they're all posted on the FHIR platform, they're free open source tools. And one of them will convert any of the clinical trials on the the registry, the clinicaltrials.gov registry. You just type in its number. They all have numbers. I meant to point that out, but they're just simple numbers. Or you can actually search for them based on text. And they convert them into a group of FHIR resources. And these resources were actually developed by this accelerator. They're very complex resources, as you might imagine. This is just a small part of the research study resource. But given that, the team used Google Gemini to abstract the clinical terms in the inclusion and exclusion criteria. And here you see a bit of what they look like. And they used 2 techniques: term frequency, inverse document frequency, vector mapping, and cosine similarity, trial rating against the FHIR information, and determine what the most relevant clinical trials for the make-believe patient was. They're using a synthetic patient, and you see them listed here. Now, starting last year, we began to post the projects that are done by the students so that people, maybe you're interested, can go and see the kind of things the students did. These posts, I probably should have shown you this, might include a text description. They might include a video explaining the project done by the students. And in some cases, you can actually run the project. And it's all public. There's a URL at the bottom. I don't know if you're going to send a PDF of this presentation around or not, but I'd be happy to provide it to anybody who wants. We just brought up a new redesigned version of the project gallery. This is it. And I did a bit of manipulation and made the 3 projects that I have mentioned to you come up first. They don't actually come up. 2 of them do, but they all 3 don't if you go there. We also introduced some new technology this year for the students to use. I don't know if anybody's using them yet. I'll find out in a couple of weeks when they make their final presentations. But if you kept up with Josh Mandel, the chief architect for healthcare for Microsoft and the chief architect of the SMART project, he recently introduced Kiln, a conversationally based tool for developing synthetic health data. This is an actual prompt that Josh put together. I asked him for one that would provide a longitudinal record of a patient, and he added that to Kiln. So here it's a 45-year-old male kidney transplant recipient, and we want notes over these 5 time points. And he specified what he wants in them. And it produces 5 FHIR bundles. You can actually go get them if you want. And I took the first one and fed it into ClinFHIR just to give you a bit of a feel for, it just contains the FHIR resources you might imagine, and it has quite a complicated resource graph shown in the lower right here. So if you get one of these, you can take it over to ClinFHIR and explore it. The instructors and I are doing some research this year. We hope to do a paper and a refereed publication. And we're gathering information to evaluate the student experience and their learning. And we're also going to gather and evaluate feedback about the course from all the people that are involved in it. And here's a photo of this year's students. We took that so I'd have something cute to show you at the end of the presentation. I don't know who's in the audience, but I want to reemphasize in conclusion something I said earlier. We really would like other universities to adopt the model. CSIRO is willing to provide the infrastructure, the MOOC, the app gallery, the tooling that we've developed to anyone who would like to do that. So I'll be happy to answer any questions.
Mark, thanks very much. That was really interesting. I know from my point of view as being a guest lecturer and a mentor last year, the students are, it's a pleasure to be working with them. They're keen, they're bright, and they're really willing. And it's fantastic that we're taking this step to train the next generation of students in this very critical
well, the cool thing is we're also trying to help. I mean, a number of the students in Sebastiano's course are in Queensland Health. And so we're hoping that we're creating some healthcare providers, professionals who have a much deeper understanding of digital health and can hopefully help play a role in faster adoption there and elsewhere. So that's an interesting model too. Obviously, most of the students are from Queensland, given that that's where we are, but the same thing could be done anywhere in Australia.
So I'm going to open up the questions. If you would like to raise your hand. Sorry, Sophie, I know you've had your hand up for a long time. I've just opened. You're on mute, but if you want to ask a question.
Apologies. I think that was an error on my behalf.
Okay, no problem. That's all right. If anyone else would like to ask a question, please raise your hand and I'll open it up. David.
Yeah, g'day. Sorry, I threw it in the note there, but it was sounding like, g'day, Mark. Thanks for sharing all that. So we're getting to the point where these apps, these FHIR apps that these projects are using, are they going to become like things we can either purchase or license so that we're just orchestrating new capabilities by, stitching them all together?
Well, under university policy, and this is true in all, pretty much all universities, students who develop stuff like this as part of taking a course own the IP. Now, in my experience, very few students are going to actually try to do anything with it. The exception from last year may be this clinical trial matching app. So if you go to the gallery and you see anything that interests you, we don't post students' email addresses, but notify us, and we certainly try to see if the students are interested in talking to you about it. I mean, the odds are they'd be happy for you to take the app and work with it.
Oh, yeah. Okay, thanks for that.
And look, Mark, if you
Actually, I'm gonna talk to. So, Dave, it's a very interesting question. I'm going to talk to my colleague Chelsea at UQ and see if we couldn't add something to the app gallery. Sort of interested in adopting one of these apps. Here's what you do.
Yeah.
That's a good
Yeah.
idea. It's a real good idea.
And we can send around the link to that gallery. That's all right, isn't it, Mark? To all
Well,
the
yeah,
participants?
I'll put it in the chat. Give me
All
a
right.
second.
Thank
I'm
you.
looking at it right now. It's good.
It's there's still a few tweaks that we're going to add, but it's good enough for right now. Right now, you can only search based on it's good for everyone, or it's good for patients, or it's good for clinicians. And Chelsea is posting just about everything we have, but she's got a little bit more of that to do. And when she's done that, we're going to see if we can come up with some other categories.
From what I understand with FHIR too, though, isn't it like there's FHIR, the international standard, then there's the US version and the UK version, or and we're doing our Australian version, or
Yeah, well, there's AUCDI, which is what Sparked is developing, and that project's actually under the leadership of the group here at FHIR. So what that will become, it certainly has become in the United States, is kind of the minimum data set. I mean, you got to at least support this, but it's not saying you can't do anything else. I mean, nobody would want to do that.
no.
So now, once AUCDI is done for real, we will probably tell the students to try to keep their projects within the context of AUCDI if they can, but their project may require something that is going to be outside of the bounds of AUCDI, but certainly where there's an overlap, we'll ask them to stick within the specifications of AUCDI. And that's not a big problem.
David, did you mean to raise your hand and ask another question? Go ahead.
Yes. Yeah, no, it's I was just wanted to be upfront with you too, Mark, that I am very fortunate to be working with CSIRO on both that CDG and the technical group as well. Just my experience in software development is angle, because as far as health data goes, my God, you got this crazy stuff you guys are working with. I come from financial services, transportation background. So, but the practice that you're implementing, doing standards, I've done a lot of different standards, so it's really fascinating to see how it's developing.
Yeah, well, thank you for your help. One of the things that I think makes healthcare unique is the robustness of the data standards we already have, with SNOMED being at the top of the list. I mean, SNOMED began as an idea at NIH in the early 70s. I know because I was a medical student and took a semester there and actually worked with Scotty Pratt, the guy who invented it. And it evolved over many decades into one of the most robust standards, ontologies really, that exist in any field. And now I'm very excited to see we're really in a position to take advantage of it. And it has some really interesting applications to AI, which I'm not going to go into because that's not what this lecture is about. But we've been great as an industry in developing these robust standards. We haven't been too good at using them. And that, along with that, needs to be part of adopting FHIR and SMART, and AUCDI is all about that too. I mean, it's really important.
All right. Are there any other questions? Any other questions for Mark? All right. Well, we're a bit over time anyway, but I'm going to say, Mark, thank you very, very much. It's interesting. It's always interesting to hear from you. As I said, I think it's a terrific course, and we're very lucky to be having you here, helping us along in Australia with that course. It's very important. So thank you very much for your time. And
I just have one final ask. If you have good connections in any university here in Australia, go over there and knock on their head and tell them they ought to think about this.
Yep, I think that's a good idea too. All right. Thank you very much, everyone, for your time at lunchtime. And we'll see you next time for the next one. Thanks, everyone. Bye.